Let's dive straight into high-yield Step 2 CK decision logic for miscellaneous dermatology, infestations, burns, and vascular tumors. We're bypassing the basic definitions here. Instead, we're focusing entirely on the clinical presentations, the underlying mechanisms, and the next best management steps you actually need to recognize on exam day. Establishing your decision logic framework means rapidly mapping out key diagnostic differentials. When you see these clinical vignettes, you want to categorize morphology and distribution right away. Look for the classic splits. Is it elderly forearm bruising with normal labs, or rough follicular papules on the posterior arms? Are you looking at a rapidly painful ulcer with a violaceous border, or nocturnal pruritus and linear bites? Recognizing specific triggers, like smoke exposure versus an electrical injury, or vascular lesions and lymphedema versus immunosuppression, that's what immediately directs your diagnostic workup and your treatment plan. Let's look at senile purpura. Notice the characteristic painless, non-pruritic ecchymoses right on the hands and forearms. The mechanism here is age-related connective tissue and vessel fragility. The vessels just lack sufficient structural support, so even minor trauma causes them to rupture. As those extravasated red blood cells degrade, they leave behind this residual brown pigmentation from hemosiderin. The key testing feature for you to remember: these older adult patients will present with completely normal platelet counts and normal coagulation studies. So how do you distinguish senile purpura from systemic bleeding disorders? It requires careful clinical logic. When a vignette gives you an elderly patient with significant bruising, first exclude a concerning bleeding history or a medication effect. Once you've confirmed that both the coagulation studies and platelet counts are within normal limits, your diagnosis of senile purpura is locked in. At that stage, reassurance is the right management step. No need for further invasive testing or specialized therapies. Moving to another highly tested popular presentation, pseudofolliculitis barbae. This shows up as inflammatory papules or pustules in the beard or neck areas. It happens when curved hair is cut short during shaving and then re-enters the skin. That causes a foreign body inflammatory reaction. We see this much more commonly in patients with tightly curled hair. And if it's left unmanaged, complications can include post-inflammatory hyperpigmentation, secondary bacterial infections, and the formation of keloids. For the management steps of pseudofolliculitis barbae, prioritize eliminating that mechanical trigger. The first-line recommendation: stop shaving altogether if possible. But if the patient must groom their facial hair, they should change their technique. Tell them to use clippers instead of a close razor, and always shave with the grain of the hair, not against it. If they already have an active secondary bacterial infection or significant inflammation, you'll want to target those specific symptoms with appropriate topical therapies. Now, contrasting with shaving triggers, keratosis pilaris presents as small, painless rough papules. The defining pathophysiology here involves retained keratin plugs right within the hair follicles. And this is often accompanied by perifollicular erythema, mostly located on the posterior upper arms. Patients will frequently tell you the condition worsens in cold or dry weather. Your treatment focuses on softening that keratin, making emollients and keratolytics, specifically salicylic acid or urea, the correct therapeutic choices. Take a close look at the distinct progression of pyoderma gangrenosum. It usually starts as just a simple papule or pustule, but then it rapidly expands into a painful ulcer with a purulent base and an irregular violaceous border. The underlying mechanism to know is a neutrophilic dermatosis associated with pathergy. Now, pathergy means that any trauma to the skin, even something minor, can worsen ulceration or cause new lesions to form. Keep that in mind, as it's a critical factor for how you manage these patients. The diagnostic logic for pyoderma gangrenosum requires you to first associate it with underlying systemic conditions. Think inflammatory bowel disease, inflammatory arthritis, and malignancy. You diagnose this clinically, but only after excluding mimics like cutaneous infections, venous ulcers, vasculitis, and cancer. A biopsy of the ulcer margin is recommended to support the diagnosis by showing mixed neutrophil predominant inflammation. Here's a major clinical pearl: avoid surgical debridement. Because of that pathergy we just talked about, cutting into the tissue will actually enlarge the wound. Treat it using local or systemic glucocorticoids or other immunosuppression, depending on the severity. Let's shift gears to infestation distribution, which gives you highly specific physical exam findings. Bed bugs typically bite on exposed, unclothed skin during the night. This results in pruritic maculopapules or puncta arranged in linear groups. You'll often hear this described as the breakfast, lunch, and dinner pattern. On the flip side, pediculosis, or lice infestation, presents with widespread itching of the hair, body, or genitalia, and you'll actually see the visible louse or the nits attached right to the hair shafts. Scabies gives us another distinct diagnostic pattern. It spreads through direct person-to-person contact, causing intense pruritus that's characteristically worse at night. The distribution is your key here. Look for erythematous papules or thin serpiginous burrows in intertriginous areas, places like the finger webs, flexor wrists, elbows, axilla, umbilicus, and genitalia. While the diagnosis is usually clinical, skin scraping with microscopy is confirmatory. Treatment requires topical permethrin or oral ivermectin, and it is critical that you treat household members and close personal contacts at the exact same time, while also washing all bedding and clothing.
Moving on to thermal burns, initial care always starts with the primary survey: airway, breathing, circulation. Then move to pain control and removing the heat source, clothing, and any restrictive jewelry. For major burns covering more than 20% of the total body surface area, your immediate priority shifts. You need formula-guided intravenous fluid resuscitation and early enteral nutrition to support their high metabolic demands. You'll titrate those fluids based on close monitoring, which means placing a Foley catheter early to accurately track urine output as an indicator of adequate perfusion.
The crucial point regarding inhalation injury is recognizing the warning signs early before the airway is completely lost. Your suspicion needs to be high if the patient presents with facial burns, soot in the oropharynx, singed nasal hair, hoarseness, or stridor. An enclosed space fire history, hypoxemia, altered mental status, or elevated carboxyhemoglobin levels are also major red flags. When you see these clinical findings, strongly consider early intubation to secure the airway before progressive edema makes it impossible. When you're evaluating a burn wound infection, the timeline dictates your suspicion. There's a common testing trap here regarding antibiotics. You do not give prophylactic systemic antibiotics for uncomplicated thermal burns. Doing that only selects for resistant organisms. However, if an infection does develop, the timeframe tells you what to suspect. Early infections, usually within the first few days, are predominantly caused by gram-positive organisms. As time goes on, later infections raise significant concern for gram-negative organisms, like Pseudomonas, and eventually fungal pathogens. Electrical burns present a very unique diagnostic challenge. Why? Because the visible external skin injury often severely underestimates the extent of the deep tissue damage. As the electrical current travels through the body, it causes extensive muscle necrosis. Complications you must monitor for include rhabdomyolysis, compartment syndrome, cardiac arrhythmias, and myoglobinuric acute kidney injury. Your diagnostic workup should include checking an ECG, creatinine kinase, electrolytes, renal function, and urine myoglobin. Treatment involves aggressive IV fluids, targeting a high urine output to flush the myoglobin, alongside prompt management of any compartments or arrhythmias. Let's wrap up with vascular tumors. Secondary angiosarcoma presents a very specific risk profile. It appears as purpuric nodules and patches without distinct borders. The clinical logic here requires you to connect this morphology to two highly tested risk factors: chronic lymphedema, like what might happen in an arm after an axillary lymph node dissection for breast cancer, and prior radiation therapy to the area. A timely biopsy is recommended because this malignancy readily metastasizes.
Pyogenic granuloma presents quite differently. Also known as a lobar capillary hemangioma, this is a benign vascular tumor made up of abnormal capillaries in granulation tissue. It typically presents as a rapidly growing, friable, dome-shaped red papule on the hands, trunk, or oral mucosa. Its defining characteristic is that it bleeds very easily with even the most minor trauma. These lesions are frequently triggered by local injury or the hormonal changes of pregnancy.
Differentiating vascular tumors and immunocompromised patients is a classic Step 2 CK comparison. Both can present with reddish, purple papules and nodules in patients with advanced HIV. So how do you tell them apart? Bacillary angiomatosis is caused by a Bartonella infection. It often involves systemic symptoms, and the diagnosis is supported by finding bacilli on a Werthen-Starry stain. Kaposi sarcoma, on the other hand, is driven by human herpes virus 8. It presents with violaceous skin and mucosal lesions, and the primary management hinges on initiating or optimizing antiretroviral therapy. Recognizing the subtle differences in their histology and infectious triggers is what will guide your final clinical decision.